Hey everybody, so today just wanted to review a quick overview of how we look at cone beam images in a clinical setting and what we kind of review with the patient. So I'll just hop right to. So when I get the scan pulled up, usually my team does this, but I'll kind of show you. We'll hit the orient button, and that just allows us to center the scan if needed, just depending on the patient positioning. That allows us to make sure that things are level and on plane. And then typically, I'll start at the tip of the nose and work my way back. And so I'll just zoom in here. And some things that I'll note are see some collapse of that nasal valve. And then as we get back and see the nasal septum, we see a pronounced deviation to the left and a little bit of a bone spur. And then we do see some inferior turbinate hypertrophy as well. And that's significant as most of the airflow is in between the middle and inferior turbinates. So when it's blocked like that, we then start to ask the patient some questions as to what else could be going on and what symptoms that might be causing. And this patient in particular, chronic allergies, chronic nasal stuffiness, mouth breathing, kind of you name it. And so getting this picture is pretty profound. So I'll look through these slices and kind of walk my way back, making note of any abnormal findings, looking at the ethmoid and sphenoid sinuses. And then you get a little picture of the jaw joints here as well. And you can see there's definitely some degeneration, but I'll show you how to get a better look at that. And then I'll always go through this sagittal view and I'll look at the teeth, make sure we don't see any periapical abscesses, bone loss. The patient's in the middle of having an implant restored, as you can tell. But the rest of the dentition looks okay, some dental work for sure, and can kind of pan through those views. As we look at the volume render, the thing that's really pronounced are the pronounced gonial angles. And so usually we'll see that in patients with mouth breathing or bruxism. And then, allows us to look at it from all three sides. The stylohyoid ligament is definitely shows some calcification. In this case, actually the stylomandibular ligament, but you'll see that on that 3D rendering quite easily. We do look at the airway function. To be honest, I don't talk a lot about it with the patient as it's an upright, awake position. And so kind of is what it is. It could change based on what the patient position they're in. But I can tell a patient this, look, at this position, it's likely not going to get better at nighttime. So we will comment on it, but I usually don't hang my hat on that for any sort of diagnosis or anything. But sometimes it is nice to look at the coronal view and see if you see any encroaching of those tonsils in the airway space or the adenoids or things like that. So we definitely will look at that airway volume render. And then as we go to the pano, down here on the bottom, you want to select your field of view and get the trough that would make the pano. So sometimes you'll just have to adjust the field of view to get it in focus, and then you can hit the create pano button, and that'll give you a good digital rendering of that pano, and then it allows you to look at it. So here you definitely can see some degenerative changes in the joint, but really the best view for that is right here over in the TMJ section. So similarly, you want to make sure it's centered, and then you'll grab these field boxes and you want to get them at right angles to the joint. And it's going to be tough is some patients aren't symmetrical, so they're going to be in different planes. If you go to move one of these and not the other and both move, the symmetry button over here might be clicked. And so you want to unclick that. So then I bring both condyles into the field of view. And then by holding the control button, I can zoom in. And then by holding the shift, I can toggle. And that allows me to look at the joint then in all three dimensions. So as you can tell here, there's a subchondral cyst, there's severe sclerotic changes of the condyle, loss of joint space, and pretty significant in a 36-year-old male to see these changes. And then we can evaluate the articular eminence as well. And here the articular eminence on the left looks okay. Some sclerosis as we get to the lateral aspect, and then a severe loss of condylar height as well in that region. So looking at the condyles from these different dimensions gives us a lot of insight. And then what's really cool, you can kind of just go over here, hit capture to gallery, and now you're capturing. You can put any comments, you can put severe degeneration, and then you can save these in the gallery and then upload them to the patient's chart, send them to a referring doctor, whatever you may do with that. And there's so much in this software, placing implants and stuff like that. And a lot of the cone beam softwares have it. So just getting familiar with it and kind of getting a look at these structures would help. But I would say in the patient, based on how many questions they have, we can go through the scan, take our screenshots, make notes of it, and do it in just a couple of minutes. And I think the best education, so a tip I would have if you're getting comfortable with this, is take this scan, do your eval, make your notes, and then send it to a CBCT review service radiologist, and then take your report that you made compared with the radiologist report, and that's your best education. And if you can find a service like Beam Readers or some of the others that have screenshots, that's the best, because then you actually see what they're looking at. And so that's a great way to educate yourself and study your scans. And I would say just build a patient for it. Tell the patient, hey, I'm going to send this to a radiologist. It's going to be an extra $100. You can defer on sending it, but I think it's in your best interest to have it read by a radiologist as well. And so I would say my first 1,000 scans or so I sent to a radiologist, and it was great to sit down and study those. I usually kept them, so I had about 10 to 20, and then I would just go through 10 or 20 scans at a time, make some notes, and I think that's the best way to learn how to read these things. I hope you found benefit in that, and thanks for having me.